and we continue with the program. In fact, this was
Do you have connection with the cat lab?
what happened with the live case in the cat lab? Are they ready? Please tell us no.
I don't know. It's good afternoon. So,
Hello, guys. Are you ready to show what is the situation in the cat lab? Dr. Palena?
yes, Professor Petrov.
Yes, I'm hearing very well. Professor.
Okay, fantastic.
Yeah.
Super. So, welcome to the cat lab. Here we are waiting, fighting and working with a young patient. He is 46 years old, smoker, many risk factor, and for sure, clearly Burger disease. Which we start with a 6 French antigrade sheath.
Okay, excellent. We see everything now. Great. Please share with us everything.
Oh, okay, super. Yeah, so can you show the image?
The first image.
So as I said, we did a 6 French antegrade access in the common femoral. We put a short sheath, and the patient was already studied before, so we know he has a healthy fem-pop axis. So we start with an enzo from the popliteal artery that show us this, the ostium of anterior and nothing else. Go distally. So occlusion of distal anterior, occlusion of peroneal, occlusion of posterior tibial with some collaterals through the peroneal very distal, and what we call a desert foot. So no any vessel in the foot, just some small and tortuous collaterals. That seems to feed something distal, but yeah, I was not able to identify any main vessel. So we did an attempt through the anterior tibia with Oscar. Oscar device was very nice. Oscar is a 3-element device, a supracatheter, a dilator, and a balloon. We combined the supracatheter with the dilator. Wait. With the dilator, and we were able to engage the anterior tibial and to go downstairs till the ankle, but there was no way to cross the dorsalis pedis. I forced, and we finished out of the artery. So we did the same job. Engaging the TP trunk, we crossed the TP trunk, the posterior tibia, we arrived at the ankle level and the same situation. No way to cross any of both plantar arteries, and finally we finish out in the plantar aspect. So in front of no any option because there was nothing to be punctured distally. I checked with the ultrasound, I find out a posterior tibial vein. So we punctured the posterior tibial vein, we put a 4 French sheath. You can see the sheath in the vein. We did a small injection. We check, and with a wire in the vein and with the wire in the artery, we tried to cross from the artery to the vein. It failed, so we did a double.
Just to say that the statue you tried with this.
Yeah, okay. Yeah, you can show the previous one a bit. I tried to pass from the artery to the vein with a stato 30. I was so close, but unfortunately, not sure to be in the vein lumen. So we put a 4 French sheath in the vein, and with a double catheter and double snare, this is the strategy. We punctured the snares, passing through both snares. As you can see, we were through both the snares. We put an 014 guide wire, and after this, we retrieve the first snare in the vein, the second snare in the artery. This is the vein side. Finally, we retrieve the artery side, and we did the fistula, the DVA. We connect the artery with the vein. Finally, we pass anterally a catheter, and with the second wire, we were able to finally manage to cross all the valves. Yeah, we have some difficulties in the plantar side even, but finally we finish in the anterior circulation, venous circulation. We start to predilate at 3 millimeters everything, and after this, we check there was flow in the vein and in the artery, but still the sheath in the place and some valves. So we pass to 4 millimeter balloon, very long balloon, to do the final angio. You can see the valves that we have been dilating. We shift the wire from the dorsal circulation into, back one, into the medium marginal vein. So from deep vein system into the superficial vein system. This is the medium marginal vein and connect with saphenous vein. You can see now the guide wire, O14 wire in the saphenous vein, great saphenous vein. And we did the final dilatation of this venous arch and all the system at 4 millimeters, included all the posterior tibial artery. You can see now the connection point and the arterial angioplasty. And we did 3 minutes everywhere, and we just finished now. So we are going to remove the 4 millimeter balloon and to do a check to see if we have a functional fistula, functional DVA or not. Let's start, sorry, it was my mistake. Let's start at the ankle level and at the foot level. This is contrast, super. Because we had previously arterial flow, so let's see now if we have even venous flow. No, it was water. Sorry, go. Sorry guys, it was water. I will provide you a check with contrast. Yeah, that's it. Fantastic. So still some valves functioning and creating problems. Good luck now to discuss with you and to know what's your opinion. This is a no proximal DVA. There are not too many veins collaterals, so it's good. So now the options are between to put stent or not put stent. What do you think, guys? Comments? Critics, advices. Let's go downstairs again to do a new.
What was the size of the balloon for predilatation of the veins system?
3. To predilate was 3, but we finally did a 4.
Yeah, maybe
we did a 4
maybe
millimeter.
You should advance the balloon with a higher, larger balloon.
No, I don't think so, because it's quite risky to broken the arteries, the vein. And finally, if we go with a higher or bigger balloon, what we will obtain is a mismatch between the artery and the vein. That's what I want to avoid. Look, this is the same balloon than before. You can pretty well see that there are at least one valve that is not answering pretty well to the balloon because the balloon remains still compressed. Let's try to do another 3 minutes. Yeah, now it's open. Let's try to do another 3 minutes.
Sorry,
here.
Mariam, can you center the magnify here, the camera?
At the
Here?
foot?
At the foot?
Wait, that we will move in the way. Okay. So this is.
Magnify.
That's pretty well. This is the balloon inflated in the medium marginal vein. That is a superficial system, so we can see pretty well. And that's the reason why we cannot think to use a big balloon, because 4 millimeters is more than enough. The problem is not with the diameter of the veins, that for sure can maybe resist even 5 or 6, but the problem is with the valves. So in the future we hope and we wait to have a valvulotomy, a percutaneous valvulotomy, to pass it and retrieve the valves. Another option is to use a cutting balloon, semi-inflated, retrieving it and cutting the valves. Sometimes it functions, sometimes not. The risk with the cutting balloon is to broken the valves and have the flaps of the valves navigating that could create some thrombosis. So From my side, after two attempts to manage the valves, what I used to do is to put stent, a self-expandable pulsar T3 stent from the artery into the vein, covering all the veins till the base of the fifth toe, and the way to be sure that I don't have any other valves that can be functioning. But yeah, I think this is the focus of the discussion. I mean, completely failure in the arterial revascularization because we were not able to manage the foot arteries. We cross anterior and posterior, but impossible to manage the foot arteries. So that was why the decision to do the DVA, and I would like to hear your opinion about that, as well as how to manage the DVA for the final treatment now that we did it.
Yeah, it's a sad disease.
Yeah,
Small artery disease, yeah. And maybe we should give some recommendations about the therapy after DVA.
Yeah, for sure. If we deploy stent, I would like to have him in triple therapy, so aspirin, clopidogrel, and Xarelto. He's young, so low risk of bleeding, and Xarelto 2.5 twice allow us to be quite safe with the bleeding.
Safe side.
If we deploy stent, for sure. If not, even if not deploying stent, I think it could be a good option for him to be sure that this.
And the
his
most
stent
important thing,
correct.
quit smoking.
Yeah, well, we know, all the smokers know that to stop smoking is quite difficult, and that this is the biggest problem with this population, this type of patients. We for sure will ask him and will advise him to stop smoking, but we also know that it's going to be quite difficult for him to completely stop and to succeed. And even if he stops, he's going to reduce the inflammatory effect, but the damage of the arteries is already done.
Yes.
So the risk for him to suffer a major amputation is so high, so big,
What is
so big.
the opinion about quitting cigarettes in smokers? 100% with hiring the stress because of quitting. Because the stress is the number one risk of atherosclerotic disease, first of all. And when we cut the cigarettes from these smokers, we introduce them a new stress, bigger stress. Is it better to quit
Yeah, well, it's a vicious
100%
cycle.
or maybe to stay with 5 cigarettes per day?
Maybe some alternative.
Yeah. Alcohol. Rakia.
To reduce the stress.
Yeah, exactly. As an anti-stress.
Yeah. So if you put a covered stent, what type do you prefer?
In this type of distal DVA, I never put cover stent.
Never.
I use cover stent for the proximal DVA because you have a big vein that is taking out the flow. When you do the distal DVA, and some cases we succeed to do it more distally, I don't think so you need cover stent because you don't have too much collaterals. The blood flow that is coming back is passing through the foot and is coming back. So I don't think so that in this case we will need cover stent. When we use, if you use the lymph flow system, as a very high cost, in Italy is prohibitive, as well in Spain. I don't know here, but I think
We
it's
do
the
not
same.
have it.
Yeah,
We
exactly.
do not have it.
Lymph flow has provided this own cover stent. Otherwise, any type of cover stent can function well. I did a couple of cases with Fluency, the very old style BD stent, cover stent. It's so complex because it's so big. You need to put a 8 or 9 French sheath, and it's quite difficult to have the stent passing through the through the DVA. Otherwise, any cover stent can perform. Well. Yeah. I think the best thing with the lymph flow is that the stent is tapered, is conic. And this is something that we cannot obtain with the other stent. And that's the reason why I like to dilate the artery and the vein at the same diameter.
Okay. Do you have some complications when you do these dilatations, especially in diabetic patients?
No, with this dilatation. I had complications for sure with DVA as well without DVA. The biggest or the most frequent was to have the artery as well the vein damage related to the dilatation or something else. But the most frequent situation is to don't have flow. What means that you dilate and dilate and dilate multiple times and you don't obtain a flow. And yeah, this is not a complication, but it's a failure of the treatment.
When you have this excessive calcinosis in such patients or in patients with chronic kidney disease, can we use for example, the shockwave system to open the artery?
Yeah, for sure. Combine the treatment, the therapies, it always helps too much. For sure, it helps. For example, but those patients are who most frequently finish with the proximal DVA because you cannot pass the tibial artery. So we connect in the ostium of posterior or in the popliteal artery. And yeah, the shockwave can help for sure, as well as some atherectomy device. And for sure, in those cases, we use cover stents. And we need just to treat the connection and to exclude all the collaterals.
And a little bit provocative question. What in such patients with Buerger disease, do you think that DCB has place there or no?
I don't think so. Honestly, I had, and I saw in the past some other colleagues' experience, I had a big aneurysm in posterior tibial, 3 millimeter DCB, became 5.5 millimeters artery after DCB in a Buerger disease patient. The same experience Roberto Ferraresi told me it happened to him too in the Buerger cases. So honestly, I think we are in front of a completely different pathology that is an inflammatory arterial disease that we don't know how to manage properly because our experience is much more in atherosclerosis patients and in diabetic patients compared to this inflammatory disease.
Maybe this is my theory. Maybe the bullfrog device will be better for such patients.
Could be for sure. It could be because allow you to inject any type of everything you want. But it's again a cycle. If you use corticosteroids with them, you will have calcified arteries because cortisone is the main reason to have calcifications, more than dialysis. The worst patients are the patients that they did dialysis, did a kidney transplantation, and used corticosteroid for a long period of time, because this is a very bad combination, the worst combination, and the calcifications in those arteries are so hard, so difficult to cross, to crack, and to open and to manage in any way. So again, use corticosteroids. I don't know if it's the best solution, but for sure, what we are doing today to manage them is the same that we do for diabetic patients, but we are in front of a different population. Young patient without calcium, with a big aggressive SAD, small artery disease, without outflow in the food, and with a very different situation. Okay. That's my point of view.
Okay. If there is some questions from the panel?
Will you try
from the audience?
Yeah, about the patients with the kidney disease, as doctor says, is quite heavy calcium, is like a cement. You cannot cross it, you cannot predilatate it. I'm not even sure about the shockwave in those cases can do something.
You have questions?
And this is a very difficult situation because these patients has below the knee severe occlusions with severe calcification. and maybe the externalization, arterialization of the vein is the maybe only choice, but although in those cases, even the vein is calcified as the arteria.
Yeah, this is a problem, for sure, you are right. When you have calcium in the arteries, you also have calcium in the veins. Okay, this is the result. Still some active valves, but not bad, not too much collaterals taking out our flow. So this is a case in which I will deploy stent, for sure, because we have a valve that is not fully open, and it will provide us direct flow, better flow, faster flow.
Yes,
Yeah, for sure you have pulse, for sure you have, but the valve is there.
Yeah, the valve
You
is
can
there.
see that how the flow finally opened the valve. So if you agree, if we have a 5 millimeter pulse at T3, 200, I would like to start with this, at least to cover the valves.
We have question from our auditorium.
How big the
5 millimeter, 200.
Nadine,
Dido,
can
do
you
you have
hear
one?
us?
No.
Stent. Ah. Да.
Okay, let's see. In the meanwhile, guys from the audience and from the panel, do you agree with the stent use, or some one of you would like to continue the dilatation? How do you see it?
No, stents, it's definitely. You cannot,
For
we
me too.
didn't achieve
There is
anything
no
with the
point
ballooning.
for more
Yeah.
dilatations.
Yeah. We have a question from the audience here.
Yeah.
На
Nedvin.
200 няма.
Can I ask you?
150?
Nedvin,
150, yeah. Yeah. That's
Nedvin,
Yes.
we have a question from the audience, please.
Will
Yes.
you, Nelo, hi, this is Dimitar Nikov. Will you try in this session, and
Yeah.
Mariano, to you, to try to damage the valves of the metatarsal veins or some of the metatarsal veins, and or wait on second stage to improve the
Sorry, I
distal?
don't understand the question. You were talking about focalization and vein embolization?
No. To try
Can
to
you repeat?
Can,
Dr. Nikov, can you repeat the
Okay,
question?
okay. Will you try in this session to improve the flow to the metatarsal veins? Some damage
How
of
do you
the
think we
valves.
can improve the...
I don't know.
How do you think we can improve? Okay, good
Well,
question.
maybe manipulating with wires or something.
The last,
I don't know.
no, wait. The last paper, no, don't move.
Не мърдай.
Okay, it's in the metatarsal artery. The last research done by our colleagues, Bruno Migliara, that he has, look, this is the problem with the stent. Give me an 018 wire, please. That's the reason why I use Pulsar, because Pulsar is 4 French and always pass. Now, this is not 4 French and it's 035, so it doesn't pass. The idea is to, the suggestion from all of them with the big experience doing this is to go in the medium marginal vein. This is what we did. For sure, to open the flow in the metatarsal veins is not easy. It's not secure. The 018 one, the command 18.
Команда, да.
This is a command? No, this is not command. This is the status. The command probably finish. We don't know where.
No, it's here, it's here.
So there is no way to try to manage the metatarsal veins. The idea is to have the better flow as possible for the forefoot.
Do you want to change it?
No, I want to put both. In the way to have the pressure open the metatarsal veins. So it's for sure a second stage in which in 1 month I would like to have an angio of this patient and to see how the fistula, how the DVA is performing, and if you need to focalize, but as I said, it's a second stage, and if not, maybe to do something more at the goal. Yeah. That's the reason why we need dedicated stents. And that's the reason why we are insisting to put stent, because there is a valve that do not allow the device to pass.
Maybe
Ask the
maybe we
patient to don't
can
move.
press the stents outside the from
That's
outside.
it.
Yeah.
It's okay.
That's it. A bit more. I would like to do the last centimeter, but if we stop there, it's gonna be okay. Because this region, okay, super. This region shouldn't have valves. Ask him to don't move.
Не мърдай. Ако обичаш, не мърдайте.
Okay. Ah, it's finished, it's finished. So to manage the metatarsal veins is not something easy, but the most relevant experience and data show us that the time
It's okay.
we cross the arch, and let's see, give me more contrast, please. The time we cross the arch, okay, till the medium marginal vein, we should be in the right position for a better perfusion, for a good perfusion. Okay, let's see now. We will retrieve a bit the wires inside the stent. The stent is fully expanded. Wow, that's completely different.
Yes.
That's completely different. The flow arrived in 1 second. Look, we don't have too much metatarsal veins pushing down through the toes. Even if we can go in the metatarsal veins with the balloon, but we cannot broke it. Yeah, don't move. We cannot
Не
broke
мърдай
it
малко,
out.
още малко. Не мърдай.
Let's see if now we can have the valve open. Put the foot in the middle, please. Or it's okay, it's okay, it's okay, it's okay. It's fantastic, super. Give me another contrast, please. Let's see that if the valve is now open, okay, for the first toe, with the wire in. No, the situation is the same, but for sure the wire could create spasm. So this is the situation and the result in most of those cases. And when we repeat the ends 1 month later, we can see a very good network in the forefoot.
Do you think we should proceed with the stenting above?
Yeah, absolutely. I would like to put the other 520
Okay.
to cover this distal part of the vein, or proximal, and to cover the fistula.
Има ли още един 5 на 150? 150?
Yeah.
Okay. Super.
So any question or idea? I don't know, for example, about this question of how to manage the metatarsal veins. Any suggestion? In my experience, what I used to do is always wait, even for the focalization, because you have now a network, a vein network, and the first idea is, yeah, let's put a coil in the dorsal vein, or my advice is to wait. To wait like a AV fistula for dialysis, wait till it's relatively mature
Yes.
and decide where to close, how to close, what
Нагоре
to
дай.
close.
Нагоре.
Do you agree, guys, in the audience? Hold the wire, please. Hold the wire.
Само дръж само жицата.
Yeah,
course.
because it's moving the foot
We
and you
have
feel pain for the
to
wires.
take the time now to see the results after 1 month maybe.
Okay, perfect. Super. I think we can stop here with the stent. No need to go in the TP trunk. And stent guarantee us something more, that is the possibility to reopen. What means if we have an occlusion of the DVA, having the stent, we are sure we will pass without too much difficulties inside the stent, and we will be able to open it if needed. So let's check from proximal to distal, and let's see how it's running and going, and let's us know your ideas. Wow.
Excellent result.
Yeah, 4mm TP trunk, some small dissection and the proximal posterior, but I don't think so. It's going to create any issue. The 5mm stent performed perfectly in the posterior tibial, so it looked like a bypass.
Yeah.
Very big.
So maybe another issue we should comment. We should use preferably the posterior tibial.
Yeah, always all the data available show us that the posterior tibial provide a perfusion compared to anterior tibial. Some colleagues from Italy did a good job and research from the peroneal, but it seems that finally if you don't go in the plantar side, it seems that the perfusion, we don't know why, but it seems that the perfusion is not good. Compared to the superficial DVA, that means to do a bypass from the saphenous vein into the pop.
Yes.
That is a superficial perfusion, and in that way, the dorsal circulation seems to be better, but with deep vein arterialization, it seems that the perfusion is better with the plantar veins compared to dorsal. Let's go for the foot. And let's
Розшири го направо.
open it completely. My fault.
Извинявай.
Okay. As much as possible. Okay, stop. Okay, fantastic. So let's retrieve the wires and let's see now how these foot veins can go. Yeah, I think it's very good. We have a rich vein network. Let me do an anteroposterior view in the way to see how many perfusion or how many branches you could have. Which is contrast? This? And this is water? Oh, too much. Okay, let's see if in the anteroposterior view we can identify some branches, some collaterals, another magnification, all the toes remain almost in. Yeah, super. Let's see where our stent arrive. Yeah, no branches. No, don't move. No branches for the toes. Well, you can see some arteries arriving at the end. If he stopped to move, I will do a new one.
You
The
can
last one.
tell him in Bulgarian.
Nemardej. Nemardej. The last one, Nemardej.
Последно не мърдай повече. Yeah, too much.
Yeah. Okay. I will inject a bit before in the way to avoid
Не
movement.
мърдай.
Look.
Yeah, some arteries. Yeah.
This is
Yeah, but these
these are
arteries
the
are
collaterals
coming.
from the anterior. Retrograde full fill
No,
from the
probably no. Those are there are some vein connection, arterial venous connection through collaterals of the veins, and I don't know, but
they're
those
coming.
arteries are there, providing flow, and this is the network we expect to have developed in 1 to 3 months. This is what happened usually. We have disconnected arteries that we were not able to see from the beginning and we can see finally after the VA that develop, as Roberto Ferraresi described, the neoangiogenesis in this type of procedures.
We'll
So
check after 1 month.
I think this is the way.
Yeah.
Bravo, congratulations.
The foot is pink.
Yeah, you can see the foot here. With the necrosis, we have Rutherford 5. 3 of the toes are with necrosis. Okay, thank you.
Thank you, guys. Thank you for the great case, the great discussion during the case. We learn a lot from the discussion just only.
Thank you. Professor Ivo Petrov have additional
Sorry about
case
interrupting the flow of the session, but as I mentioned, we are going to be ready to interchange several words with the patient, with the complex patient from the live case. So, Dr. Vasiliev, do you hear us? Yeah. In fact, he's in
Yes, I
Tokyo.
hear you. Do you hear us?
Excellent. Yeah, we hear you very well, and we see you. Please show us the patient.
Okay,
And,
yes. Of course.
Иване, как си?
Okay.
Здравей!
This patient?
Здравейте! Много добре.
Много добре. Окей, супер. Някакъв проблем с някой от ръцете или нещо друго? Лявата ръка,
Абсолютно
дясната?
никакъв. Не, абсолютно никакъв.
Супер. Добре.
Всичко
Чувства се добре. Okay. So it's thank you so much. It's excellent. We did. Беше много сложен случай, да знаеш, обаче стана прекрасно. Okay. Okay, so it was, in fact, in the majority of cases, we are doing all this procedure with conscious sedation. In this particular patient, we did short general anesthesia, and this is after the weaning the general anesthesia. So it's compared to the surgical approach, you can imagine what would be after the open chest and total arch replacement in this huge aneurysm. Thank you.
Thank you.
Thank you so much.
Only one question.
Yes.
Have you ever used a re-entry catheter for puncturing the stent graft?
You mean supportive re-entry catheter?
BEC, for example.
Yes, we tried several times, but in fact the needle that is we have shown here for the second penetration is dedicated for that. And because definitely there is a vector centralization by the balloon. So it's the balloon is on the tip of the catheter and it's centralizing the vector of the penetration. The BEC is slightly curved needle and is relatively short. In fact, it's quite short. In the needle, the fourth row needle is 3 centimeters. So 3 centimeters is quite enough. And
But you can use it only in small vessels. You cannot use it in a brachiocephalic trunk. Foot through.
Yeah, we can. Why? Why we cannot? What is the reason?
Because of the position and stabilization of the needle.
We are using for the subclavian, for the carotid, for the brachiocephalic, for everything.
Thank you.
Yeah.
Thank
Okay.
you, Professor Petrov.